The National Health Council, while it is a core organization for the patient advocacy community, and you ultimately control our governance, in the 1960s we expanded membership to essentially any organization that had an interest in health-related issues. So you'll see professional organizations that come in that represent provider groups. You'll see nonprofits with an interest in health, and we have a number of family caregiving organizations in that category. And you see business and industry. And that's been an interesting issue because they've actually been terrific partners at the National Health Council. But in this day and age, business and industry, in particular pharmaceutical biotech companies, have had some real challenges. We also have insurance companies in membership. And so we are really a unique organization that looks at these very complex systemic issues through the lens of a patient organization, but the governance is controlled by the patient community. It's a very interesting, very different entity in Washington, D.C. On the trade association side, which is what I'll start off with, is really how do we address the things that are important to your organization and its need. Again, the governance issues are incredibly important, as are the fiscal issues, and all the organizations have been going through some tough times with the recession. And so we do a lot of work to help support your community as you develop over the few years. And sorry, I'm having a hard time. My eyesight is not good enough to see this way, and so I'm looking behind to make sure I'm on the right slide, so forgive me. There are a lot of opportunities that go beyond just the CEOs. And so I should say that the CEOs within the National Health Council from the patient groups meet quarterly at the National Health Council, and they talk about issues that are current and issues that are important to them. We have opportunities for just about every segment of your organization to participate. So the chief financial officers meet periodically, the chief medical officers, chief communication, government relations, income development, legal. So there's an opportunity for them to come together with organizations that are similar to theirs and talk about the issues that are important to them. And they have a huge impact on what we do. And I'll talk about a policy initiative in a few moments called Modern Cures Act that really came from the chief medical officers about 6 years ago. And it has the ability to have a profound impact on how we develop treatments and diagnostics for people with chronic conditions. But it is the only place where our community comes together without interference from other sectors. So there are other entities that look at the entire nonprofit sector. That includes human services entities as well as educational services, what have you. We're the only place where just the patient advocacy community comes together and can have discussions about issues that are important to them. We provide a lot of benchmarking reports for people within the patient community. So issues like how you deal with corporate structures, how you deal with governance, how you deal with income, are sort of some of the core benchmarking reports that we produce for our member organizations. And some of them are incredibly helpful. One we've done for a long time that I'll sort of point out that is on just about every desk up on Capitol Hill in Washington is the health groups in Washington. We actually list every health-related entity that works in Washington, D.C. in this one booklet. And so it's on top of everybody's desk, and it's right top of thumbs where they can actually figure out how to get in touch with each organization and who they need to speak to within each organization. I can tell you it's a Herculean effort to produce this every 2 years, and I'd like to stop and wish somebody else would do it. So far nobody else has taken it on, so we keep doing it. An issue that is very current, and I almost don't like this photo. I actually used to live in Boston, right in between where the two bombs went off, literally. But one of the things that has come up since Boston is how do we deal with public events where you have large groups gathering. There are new issues now related to liability and safety that we're all having to think about. So we're helping our members develop new guidelines on how to do this. Interestingly enough, the world has been slow to evolve on this issue. Even if you speak with liability carriers or insurance companies, they've not yet come up with any guidelines. But our patient organizations hold large events. And so we've been looking at what are the right things to do when you have an event to ensure safety and minimize liability, have the security you need. Charity Navigator. How many people here are familiar with the issues with Charity Navigator? I know I spoke with some of your folks. I see a few hands going up. That's been an interesting issue, and you guys are doing quite well. You've got the full 4 stars, so kudos to you, but a lot of the patient organizations have been downgraded as a result of some issues that they have decided sort of unilaterally needed to change on how you evaluate the nonprofit community. So we've been having ongoing discussions with this group and trying to figure out how we address it, but it's sort of a self-appointed watchdog group that rewards charitable organizations with stars based on their criteria, which is, some of it's good, some of it's somewhat arbitrary. And they've been unilaterally changing that criteria over time without input from the affected audiences. But one of the interesting issues here is that one of our member organizations, and we had some discussions about this, took their very own criteria and applied it to Charity Navigator. Any idea how many stars they got? And we were conservative in their favor. Anyone want to venture a guess?
Less than
2, right. I think that's very interesting. One of the things that we do that I think is incredibly important is on an annual basis, we evaluate your income streams. So we look at each individual income stream that you have, and we compare that to the entire sector. So you get compared to 49 other patient organizations. And when we do that, we look at the trends over 3 years. So there's a great deal of information captured, and we compare you to the entire sector, but also to the sector that is close to your size. And you can see how you're faring. One of the things that's been challenging, though, is as we've looked at this, we are not where we would like to be. Sort of expected at this point in time, we would be back to the numbers we had pre-recession, and we're actually not. We're still lagging behind. And that's been a real challenge. And for some organizations, they're lagging quite a ways behind. I will tell you that the mid-size organizations overall are doing pretty well. And this foundation fits into that mid-size. But nobody is back to where they were pre-recession. And in fact, we saw in the last 2 previous years, we saw increases. In this year, we essentially saw most organizations flatlined. And that's disturbing. We've got a lot of work to do to figure out what's going on in the income side and why we're not moving up. The economy has been difficult, but again, I think we all sort of hoped we would be back to where we were pre-recession. One of the other things that we do that we're actually quite proud of, and I know you are a member of this organization as well, is the International Alliance of Patient Organizations. That's a group that was founded about 15 years ago. National Health Council was one of the founding organizations for this entity. It's sort of like the National Health Council at the international level. They do capacity building services for members as well as public policy for them at the international level. And I know that this foundation has been involved with this group and has actually had some really profound impact on both their ability to provide assistance, technical assistance to members, but also in the public policy world. I actually sit on the board of this group, and I can tell you it's fascinating. The issues that we face in the United States are very similar to the issues faced all over the world, but the resources and the constraints are incredibly different when you look at Sub-Saharan Africa, Latin America, Southeast Asia, and the United States or North America. Some really interesting common elements to the problems. Not necessarily requiring the same solutions, but some real opportunity to help communities around the world build up patient advocacy. You know, this sector grew in the United States about 150 years ago, and we really led the world in the creation of patient advocacy organizations. The rest of the world was very slow to react. Europe has done better than most areas, but many of the patient organizations there are funded by their governments, which makes it very difficult for them to advocate on behalf of their patients. And then in some areas, there are just such limited resources and huge constraints that it's very difficult to mobilize. But in this day and era, in particular with chronic conditions and NCDs, we've got to do better globally on these issues, and this is an organization that's really having some new impact. I'm going to change gears a little bit and talk to you about public policy and some of the issues that we work on. What you see here is We call it our matrix for what we're doing in public policy. And if you look at the bottom from the left to the right, what you see is low importance, high importance to the patient advocacy community. And from the bottom up to the top, you see low to high impact. So what we do is we plug the issues we're going to work on in this chart, and we start to see which are most important to the patient advocacy community and which are the ones we can have greatest impact. It also is a nice tool to articulate the amount of resources we're going to put behind them. So the issues that we have the highest importance and the greatest ability to impact go up in that top right-hand quadrant. Those are the issues we want to lead. Also sort of speaks to our brand. We want the National Health Council and our patient advocacy community linked to these issues. The other issues we'll partner with, engage as needed, or come in just periodically to monitor. We can't do all these issues. You've got to be focused on what's going to be your core areas. Again, they're going to be in the top quadrant, and I'm going to talk to you a little bit about some of them. I won't go into detail on all of them, but I'll pick out a few that I think are highly important for this community. Before I do that, I want to explain to you how we make our decisions about what we're going to pick. And it's an interesting process. How many people have been engaged with coalitions? I see a few hands. Coalitions are usually when organizations come together to work on a common issue. And in some cases, people confuse the National Health Council with being a coalition. And we're actually not. We are a nonprofit, just like this organization here. We have our own board of directors. We have the ability to work on public policy. It has to be meaningful to our members. But we're not a coalition. And the reason why I say that is coalitions typically work to the lowest common denominator. And what that means is it's the part that everybody can agree on. And if you can't agree on it, you usually don't move forward on that issue. So in Washington, you have a lot of coalitions promoting principles. But in this day and age, with so much noise in the public policy space, if you're going to have impact, you've got to go beyond just principles. And so folks in Capitol Hill and the administration are looking for very specific solutions. And coalitions often have a hard time to do that. The way the National Health Council works is we actually survey all of our members, not just the patient groups, but all of our members, and ask them, what are the top 3 issues you're working on? And what are the top 3 issues you think we should work on? Because they're often not the same, because remember, you are all condition specific. We are only focused on systemic issues. We look at that survey and we go through a process to decide what are the issues that are going to be most important. But we don't have any place where one party has a veto, which is what typically happens in a coalition. So all of our issues are informed by that survey. We hire the best consultants on those topic areas to help us think about those issues. We conduct our own research around them. And it includes anything from literature reviews, environmental scans, legal analysis, focus group work, deliberative juries, surveys, what have you, to really find out what people with chronic conditions think about these issues. It then goes to what we call our issue teams. And we have 3 teams, and they're really focused in on the 3 priority areas: appropriations for health research, access to care, and the development of new treatments. Everybody can participate in that issue team. So all of our members can go there. They're all chaired by senior staff from patient advocacy organizations. They then provide advice to what's called the Government Relations Affinity Group. That is limited to just the senior government relations staff of the patient organizations. They then in turn inform what is called our leadership team, which is a group of about 7 or 8 senior folks from government relations staff of the patient groups. That then makes a recommendation to the staff, who then bring it to the CEOs of the patient organizations, who then give a recommendation to the board of directors. We have a 21-member board. 11 slots are always reserved for CEOs of the patient advocacy community, and they decide what issues we're going to work on. Once we decide the issue topics, we look at what are the specific elements we want to influence, and we develop very, very specific values under that. So for example, in health reform, when the bill was going through legislation, we had 5 very specific principles, and we had 32 very specific values that we wanted in the legislation. We actually drafted our own legislative language, and every bill and every draft of a section of a bill was sent to us and we redlined it in both the House and Senate. And when the bill was finally approved, I can point to you where they cut and pasted our language into the legislation. And we got every value except for 2 into that bill. So it's far from perfect. We didn't get everything we wanted, but we had a huge amount of impact. And it was because the patient community was coming together in a united way to say these were the things that were important to us. And we were able to go into great level of detail because no one organization could hold up the process saying, I don't agree with that, or that is not exactly how I would do it. So it allowed us to move very, very quickly. So I'm going to talk to you briefly about 3 policy issues that are part of our category of what we want to lead. First has to do with the implementation of the prescription drug user. It's one of those areas that can be a little bit mind-numbing, but I'll explain it to you in a way that makes it incredibly important to people with chronic conditions. The Modern Cures Act is a legislation that I mentioned before, came from the chief medical officers, and then lastly, the implementation of health reform. So the Prescription Drug User Fee Act, this is a bill, and in this iteration, it was called FDASIA. It is the 5th iteration of this bill, and it basically says to a pharmaceutical or biologic company, if you want to have your medicine approved by the FDA, you have to submit a fee. It's sort of like if you go to get a driving license, you have to pay a fee, sort of a processing application. It's the same thing for medications. And so the pharmaceutical companies pay a fee. They're able to have their medicines reviewed. Every year, not every year, every 5 years that gets reauthorized. And when it does, they add components to the legislation. And in the past, the patient community has always waited for the pharmaceutical company and the FDA to negotiate the terms of that. And then they go to Congress and try and ask Congress to add things that they think are important. This go around, we decided to take a different tack. We actually lobbied the pharmaceutical companies and the FDA and said, here's what we want in the agreement. And we had 3 priorities. They were all included in the agreement, which then went to Congress and was passed into law. First one has to deal with the development of a benefit risk framework, and I'll speak to you in a moment as to why that's important. The second was the inclusion of biomarkers and patient-reported outcomes. This is key to transforming the development of medicines to make the process faster and to make sure that the medicines actually respond to what issues patients think are important. This is completely new and it's now part of the legislation, and as a result, pharmaceutical companies and biologic companies are actually reaching out to the patient community and saying, what are the issues that are important to you that we need to focus on when we develop medicines? The last thing was increased resources for rare diseases. I'm not sure if you're aware of this, but there are over 8,000 rare diseases in the United States or globally. For those 8,000, only about 300 of them have treatments, and most of those treatments are not very effective. And some of these conditions are life-threatening. Benefit risk framework. Now, the FDA is charged with looking at medicines to determine if they're safe and effective. At the end of the day, every medicine is not completely safe. And in fact, some of the very common medicines you take have serious side effects that can make them unsafe. And one of the best examples is aspirin. How many people have ever taken an aspirin? Just about everybody. Aspirin could not be approved by the FDA today. It is one of the most unsafe medicines on the market. So think about that. If aspirin can't be approved, the level of scrutiny that medicines go through is huge. And at the end of the day, they have to reflect the end user. If you're talking about a pain medicine like aspirin, you want it to be safe. You take it fairly routinely without thinking. But if you're a person with advanced stage pancreatic cancer, you're probably willing to take a medicine that's going to have some serious side effects. And oncology is a great example of the trade-offs here. The medicines produce a lot of harms, a lot of side effects, but they can extend life, extend quality of life. There's a balance that happens there that is not scientific. It is purely a judgment call. The FDA is charged with making this judgment as to whether or not a patient is going to get this medicine. And they do it behind closed doors. And in fact, every regulatory body in the world has no standardized benefit risk framework. something sort of astounding to me when I think about it. You know, I trust that they're going to look at safety and efficacy, but I want to know that the product's benefit risk determination is the same as the end user. Now, I'll give you an example. Have people heard of MS, multiple sclerosis? There was a drug that was approved on the market called Aspirin. It was removed from the market, and the reason it was removed was because as much as 10% of the people taking that medicine would get a brain infection, and it was deadly. Once you got the infection, you would die. So huge complications. But it was one of the few medicines that worked quite well for advanced stage MS. And when you spoke with the folks with MS, they said, you know what, I want my medicine back. And they actually had to lobby the FDA to say, no, the benefits and risks are huge, but the benefits to us for taking this medicine for quality of life, to be able to function normally with my family, to carry on a job, were so high that I'm willing to take that risk. And they actually got the product back on the market. What we're trying to do is make sure that the FDA is being very clear and transparent about how it's making these decisions. Because at the end of the day, again, they're not scientific, they're judgments. They have to reflect the value of the end user. And one of the things we often say is that we're focused in on patients. And a lot of times people don't like the word patient, but patients, people with chronic disease, are going to use the healthcare system, use medicines for the rest of their life until they die. A consumer, conversely, is somebody that only comes into the system as they need it. They're not going to use the system to manage their quality of life until they die. It's episodic. And they have a very different perspective on benefit risk. And you hear all the time from the consumer world, the FDA is producing and letting unsafe medicines out. Well, yeah, they're unsafe, but at the end of the day, if the benefits are better than the risk for the end user, they should come to market. We've asked the FDA to develop a tool that will articulate what inputs are going into the decision making around benefit risk, and to articulate that for every product at every point they make a decision. So if they get the judgment wrong, we can tell them, no, that's not correct. You need to look at it from the eyes of the actual end user. This will be the first time any regulatory body in the world has done this. Europe is following suit, as is Japan and potentially China. As part of FDASIA, or the PDUFA reauthorization bill, there's been a requirement that FDA will hold 20 meetings with the patient community to identify their feelings about benefits and risk. And there was a great deal of anxiety over this because everybody wanted their condition represented. The challenge is that even if you look just at the rare disease community, 8,000 diseases, you know, there are tens of thousands of potential diseases that they could look at, and they only have resources to look at 20. And so what we did is we grouped diseases by functions, by age, by categories they hit, and tried to divide it up into something manageable. And you'll see we came up with 18 categories. And the FDA has already announced 16 of the conditions that it will hold these meetings with. And they fall pretty well into this list. They still have 4 more to go, and we're hopeful we're going to hit each category. But it's critically important that the FDA hear from the affected community. The people making the decisions as to whether or not a product moves forward are making the benefit risk determination based on their own knowledge, which may be incredibly different from the patient community. You know, one example I'll give you of how non-static this is look at the AIDS HIV community. If you look back 15, 20 years ago, you had people going to the FDA and NIH, and they literally chained themselves to the fence, saying, we want access to medicines. And the FDA reacted by saying, we don't know if the medicines are safe or effective. And the people chained themselves to the fence and said, I don't care, I'm going to be dead in 6 months. Let me try the medicine. That was the beginning of the early access program, where you could get medicines even before they were approved. Challenge is perspectives change over time. So if you look at HIV and AIDS, that community now has a number of treatments that are highly effective. And you cannot fill a clinical trial in the United States for HIV medicines because nobody wants to stop taking the medicine that works for them. They are unwilling to take a risk on a new medicine. That's a huge change in perspective simply because the treatments have gotten better. And you see that in the oncology world, where some of the treatments that have come out have been absolutely profound. People benefit risk equation shift. It's a very non-static issue. And so one of the things that we've done is put together a tool, and here's a simplified version, that allows the patient community to go and gather the various spectrum of perspective on benefit risk. If you look at epilepsy, for example, you might have a child that has 80 seizures a day and is wearing a helmet because they fall down so often they're afraid of hurting their heads. They can't socialize, they can't function, they can't go to school. It has huge stigma for this child. But you also might have an adult end of life that has 1 seizure a year. Do you think the benefit risk equation is the same? Probably not. FDA needs to be able to stratify the perspectives across a disease state and really understand where it fits, because when they're making a decision, is that medicine for epilepsy for everybody with epilepsy? Or is it just for that adult at end of life that has 1 seizure a day? They've got to apply the right benefit risk judgment to the medicine. And this is something that they've not been terribly good at. With these sort of structured tools, even if you don't have one of those 20 meetings, you can work within your community to fill out the strata, to identify what the benefit risk perspectives are, and provide it to the FDA. In addition, you can do this outside of the meetings from the context of most people that go to the meetings are the folks that are very interested, have the resources to get there, and are ambulatory. What about people who are bedridden or disabled or have cognitive function? How do you get their perspective? How do you address the issue when it's a parent substituting her perspective for the child? How do you deal with the perspective of a middle-aged man substituting his perspective for his wife with Alzheimer's? You've really got to be able to capture the nuances of benefit risk, and FDA has to be able to use them appropriately when they make these decisions. Related to this is, how do we get the pharmaceutical and biopharmaceutical industry to respond to the products that we want? Here's an interesting issue, but most biopharmaceutical companies only develop products and involve the patient when they're in phase 3 clinical trials, which is at the very end of the process, right before they start to market the products. They don't bring us in at the front end. And it's an interesting conundrum, but if they did, we'd probably get products that reflect our interests in a much better way. Now, the easiest example to sort of get your arms around is psoriasis. People familiar with psoriasis? It's an issue that creates a skin plaque or a plaque on your skin, and it can be incredibly disfiguring. Right now, the reported outcome that is recognized for purposes of approving the drug or covering it and reimbursing it is the size of the plaque on your skin. If you speak with somebody with psoriasis, it's not the size that's important, it's the location. Is it on their face? Is it in their joint? If it's in the joint, it's hard to bend your arm. If it's on your face, it's so disfiguring, it's hard to go to school. It's hard to have relationships. It's hard to work. Those are the things that are important to people with psoriasis. And yet, nobody is targeting those issues when they develop the medicines. So what we propose is that you look at the process as a continuum. Bring the patient community in to the beginning and let us work with you to decide what it is you're going to research. Could there be a way to make the plaques not appear on your face? Is there a way to address the social stigma that comes with it? We also want to be part of what are the research questions that you're going to ask. We want to be looking at what are the right outcomes and comparators that you're going to use to evaluate this product. Not just looking at how you're going to market this or at the very end of the process. This would allow us to develop a mechanism that creates products that respond to what we want. If you look at the cancer space, you look at some of the outcomes that patients identify with nausea, constipation, all the sorts of issues that are important to them. Those are not necessarily the targets for drug companies. How do we change that? There are a lot of disincentives for them to work together. So what we've done is we've brought the FDA, NIH, the biopharmaceutical community, the patient community, the provider community, and the insurance community together in a pre-competitive space to start to look at how do we identify standards that would give patient involvement from the very beginning throughout the process so that we can get better products at the end of the day, get them approved faster so that we get access to them, and have everybody agree on what those methodologies for patient engagement would be. And they can range anywhere from one-on-one interviews, focus groups, surveys, deliberative juries, crowdsourcing, any number of mechanisms to figure this out. But how do we create the methodologies for engagement? How do we create the indicators for success? How do we develop the training program so that we can have a cadre of people with chronic conditions that can actually engage effectively? And then how do we measure that? It's one of those things that you sort of think about and you think, well, why aren't we already doing this? But it's sort of an aha moment that is just beginning that I think is going to transform the development of new treatments. Next, I'm going to tell you a little bit about modern cures. I'm curious if anybody's heard of this legislation. See, the guys here are good. This is legislation that was introduced in the last congressional session. And it was introduced with bipartisan support. And in a matter of 2.5 months, it had 50 co-sponsors, evenly split between the Republicans and Democrats. And I would challenge you to find any legislation in Congress that was evenly split between the Republicans and Democrats in this day and age. Absolutely not. It will be reintroduced in the House and Senate, but it really addresses two major components that are important to people with chronic conditions. And one is a little bit complicated, but if you're going to develop a medicine, you have to have a strong patent. And I think most people know that you have to have that patent in order to invest the $1.2 billion to develop the medicine so that you can recoup your investment afterwards, because the patent blocks generic entry to the market for a period of time. The challenge is that the rules changed about 20 years ago. It used to be that your patent, which runs for 20 years, would begin at the point the product was approved at the FDA. So you had a great deal of uncertainty as to whether or not you would get approved, but if you did, you had a guaranteed period of time to market the product without generic competition. What happened 20 years ago is we changed that, and now they run concurrently with the development time. So as you identify a new medicine, you put the R&D money into it, and it can take 7 to 15 years to develop the product. Your patent is running concurrently with that, which means that if you have a really difficult product or treatment, you come to market, you only have a few years left of your patent to protect it from generic competition. Now, ironically, you'd think that that probably doesn't happen that often. The reality is that 80 to 90% of the NIH-funded research culminates in a great idea for a new treatment without patent protection. We're spending over $30 billion a year to develop great science, but it doesn't have a patent, so it never gets developed. When you speak with the pharmaceutical biotech companies, they review potential products to decide whether or not they're going to invest money and develop them. And 80 to 90% of the time they say no. And the reason for no is not because the science behind it isn't strong, it's because the patent isn't strong. Patents don't serve social utility when it comes to the development of treatments. If you have a cure for Alzheimer's, it doesn't matter. If it doesn't have a patent, it's not going to get developed. And as much as 80 to 90% of the best scientific ideas don't qualify for a patent. A related issue is because your patent and development time are running concurrently, the really difficult areas to develop treatments, certain cancers, neurologic, autoimmune, where you want to show that it impacts progression. So think of Alzheimer's. What you really want is a medicine that stops the progression of that disease. If you're going to do a clinical trial to show that it modifies the progression, it's going to take 15 plus years, which means you come to market with only 5 years left of patent protection. And you've invested about $1.5 to $2 billion in research. And in fact, the NIH is now funding a project in Colombia with a population of people that have early onset Alzheimer's In this one community, over 60% of the population has this. And they're going to do a 15-year clinical trial. And it's being funded by the NIH because no private company is going to do it. Because by the time they come to market, they won't have a patent that will last long enough to recoup the investment. So what Modern Cures does is it says, if you've got a good treatment and it addresses an unmet medical need, which the FDA defines as a condition without a treatment or a new treatment that provides measurable health outcomes. So virtually any serious condition could potentially qualify. The FDA determines you qualify, and what it does is it protects your product from the point of approval for 15 years from generic competition. So a huge incentive to capture all those lost opportunities. A huge incentive to not dismiss a potential treatment because it's going to take too long to develop. And they'll say it's too risky. What this does is it gives them certainty that if they can produce a medicine and it addresses an unmet medical need, you can come to market and have a period of protection to recoup your investment. The second issue it deals with is companion diagnostics. This is the way that we transform how healthcare is delivered. Diagnostics have the ability to say that this medicine will work for you, but it won't work for you. And you know that you should take it, and you know it would be a waste of your time to take it, and you don't want the side effects. Oncology is the best example of this. In general, medicines work on people only 60 to 65% of the time. So those blockbuster drugs only work 60, 65% of the time. In oncology, it's often less than 10%. And so as somebody that watched family members die of cancer and take chemotherapy, not knowing if it would work on them or not, with the side effects, think about that for a moment. That's getting better because oncology has done well with diagnostics. But I watched family members take chemotherapy for 2 years. And in one case, it was 2 years wasted. Huge investment in medical expense and a huge issue for quality of life for that person. What Modern Cures does is it says, if you develop a medicine with a companion diagnostic, we'll give you 6 months to a year of additional protection from generic competition. The reason that's important is that if you develop a medicine, you want to market it to everybody with the condition. That's how you make your money. If you market it only to the people it works for, you reduce your income. So you have to give an incentive for them to reduce who they'll market to. And this actually has been held up by economists and by the biopharmaceutical industry for saying that it will double or triple the investment in companion diagnostics. So something we're really excited about. I'm going to move on to the implementation of health reform. How many people have heard of health reform? This is good. I see a lot of hands. You know, I asked the question, but there was a survey conducted by, I don't know if it was Kaiser or Commonwealth, about 3 or 4 weeks ago. About half the country thinks it was repealed. Think about that. Huge effort that we're about to undertake in 6 months. This is an area, again, where we got a lot of really great stuff into the bill. It's far from perfect. What you see here is a list of the benefits that will be covered. The legislative language was not very prescriptive in exactly what had to be in the insurance coverage you would get. And that created some challenges. What we did at the National Health Council is we actually did a report looking at what were the options for implementing health reform. How can you make these benefits as robust as they need to be? We also looked at what would be the actuarial analysis of the product. And the reason for that is the legislation has some very specific requirements on actuarial value, which I'll explain in a moment. And then we actually developed regulatory language, which we gave to the Secretary of Health and Human Services, some of which was included, some of which was not. I point this slide out, and it's based on our actuarial analysis, because the statute limits your out-of-pocket cost for an individual to $6,000. Still a lot of money, but that was actually a big win for patients. You will not have an out-of-pocket cost beyond $6,000, but you're going to have to pay the premium to get the product. Now, the premium is not set in the statute. And we are 6 months out, and we still don't know what the premiums are going to be. The premiums are going to be a real challenge for a lot of people. So what we did is we conducted an analysis of what a Blue Cross Blue Shield product, which is the typical product for federal employees, what does that cover? And if that covered, what would the premium be for a family of 4 at 250% of poverty level? Now, at 250% of poverty level, you get subsidies for both your premium and your out-of-pocket costs. So this is a family that's going to be subsidized, but one member has kidney disease, so they're going to be a high user. And what you see at the top here is you take out their necessities, rent, transportation, food, taxes, and then you add in their premiums, which are subsidized, and then you take away their out-of-pocket maximum, which is also subsidized. And then you look at how much money a family of 4 is left at the end. It's $480 a month. So $480 a month left, that makes it pretty tight. So Commonwealth did a similar analysis, and what you see highlighted is for high users. And what they mean by high users is people with chronic conditions, the people we all represent. Those people, when you look at 150 to 350% of poverty, as much as 25% are not going to be able to afford the premium if the product is a Blue Cross Blue Shield standard option package. And you have to recognize that a great thing in the statute, but there are things required that are not typically required in insurance products. Mental health, substance abuse, children's services, wellness and prevention benefits. All the things we all fought so hard to go that are going to make the premium even more expensive. So this was a real aha moment for the patient community. We couldn't simply ask for everything. We had to be judicious and look at what was most important and how do you get a balanced product. This issue also confounds the challenges we're going to have. When people start to look at the insurance products, if I'm a high user, I've got multiple chronic conditions and I know I'm going to hit that $6,000 out-of-pocket cost in both my medical and prescription benefits. I'm just going to go with the lowest product because I know once I hit my out-of-pocket cost, it's all covered, right? That's what you would think intuitively. But because of the actuarial value calculations that have to happen, and there are going to be 4 plans offered from bronze all the way to platinum, if you're a platinum plan, you're probably not going to be able to have a $6,000 out-of-pocket cost because you can't meet the actuarial value. And I'll step back. How many people know what actuarial value means in this context? Yeah, you're like me. I heard it. I had no idea. I saw a couple of hands, but I had no idea. What it basically means is you look at the average person within your pool and what they're going to cost in terms of benefit. And that becomes your actuarial value. Now you have some that are going to be higher than that, some that are lower, but that sets the value of the plan and sets the premium charge that the insurance company can charge you. To get to a platinum plan, typically, in many cases, the only way to do it is to have a very low out-of-pocket cost. So if you look at this, if you choose a platinum plan, you're going to pay $5,200 in premium, whereas you'd only pay $3,400 under the bronze plan, which sort of tempts you to go that way. But when you add in the out-of-pocket cost, you see that the most expensive plan is the gold one. The cheapest plan is your platinum plan. It speaks to the challenges we're going to have in helping people get to the right plan that has the best coverage for their medical needs as well as their pharmacy needs and at the lowest cost. It's going to be incredibly complicated. I show you this sign because what we advocated for with the patient community to HHS was that we had to have a very broad definition of benefits with a specific list of exclusions. Does anybody have any idea why? Any guesses? No? All right, I'll just tell you. A lot of patient groups actually advocated for an explicit list of what had to be included. So the cancer community came in and said, we want a colonoscopy, we want X, Y, and Z. included. We wanted this list of medicines included. The problem is, from a legal perspective, if you prescribe what has to be included and you're not on that list, you don't get it. So what happens when the next best treatment comes out? What happens if you omit a treatment? It's not covered. What we asked for and what we ultimately got was, no, just have a broad list of categories of coverage and have a very explicit list of what is not included. By doing that, the legal presumption is you're included unless you're on that exclusion list. That made it a lot easier. All we had to do is make sure that our services didn't get on the exclusionary list. So it actually created a presumption in favor of us. And then we surrounded this with protections like anti-discrimination, medical necessity provisions, navigation services, oversight at the state and federal level. Now, we had very, very specific requests, and we got a lot of it, but we didn't get all of it in the final regulations. And that's left us with some challenges, because discrimination will be there. You can't discriminate against a person with a chronic disease. You can't charge them a higher premium. You can't charge them a higher out-of-pocket cost. But we don't have very clear oversight mechanisms. We don't have provisions eliminating co-insurance for medicines. We don't have provisions in there that are going to provide the kind of protection that we really need. What you see here is a timeline. We're about 6 months out. We're about to begin the public education initiative to really get at the population that doesn't even know that this exists. And then we're going to start the open enrollment process in October. And then we're going to have to make this operational come January. So a very short period of time. And there's a lot of anxiety as to how we're actually going to get this done. If you look at this, is a map where the states in light blue are the states that the federal government is going to run the state exchanges. The dark blue are the ones where the states are going to run it themselves, and the light blue will be partnership states. So the federal government is going to be running a lot of these exchanges, at least for the first year, but the rules of the state for each exchange are going to apply. And each state is going to have a different benchmark that identifies what benefits you get in their state. So there's going to be a lot of diversity throughout the country on this. And it's left us with a great deal of challenges. How do we move forward on this? How do we get the word out? Are people familiar with Medicare Part D from a few years ago? It was implemented about 5 years ago. It's the prescription drug benefit for people on Medicare. That was a new benefit. It was unrolled. There was about a 6-month public education campaign, and it was probably the most successful operation to get a new benefit out into the general public. The hope is we'll replicate that here, but this is infinitely more complex than just a single drug benefit. This is your medical benefit and your drug benefit all combined. What we plan to do is to hold 2 webinars, one that will happen next month in July, and it will be for the federal and state staff of our patient organizations to explain exactly where we are in implementation and what they can expect in terms of timelines moving forward. The challenge is there's a lot of anxiety because you feel like you should know more. The reality is the it is not out there. Most states are still a ways off from completing their exchanges. The rules at the state level are not finalized. The protections have not been put in place. We don't even know what the insurance products are really going to look like in most states. So a great deal of work needs to be done between now and the next 6 months. And that anxiety creates a sense of, I should be doing something, but I don't know what. The reality is there's not a whole lot of what yet. In September, we'll hold another webinar, again for our federal and state staff and some volunteers, that'll look at exactly where we are, because at that point in time, we'll only be 2 months out from open enrollment. So at that point in time, we should have a great deal of detail as to how it's going to operationalize at the state level. We're also going to be developing messages that you can start to share with your constituents. And I know you have a great reach, and it will be terrific to have you putting these messages out periodically, letting people know that this benefit is out there. It was not repealed. It's calling for it. For about 40 million Americans are going to have access to care for the first time. They're going to want to know what it is and what it means. One of the things that's been interesting to me is when you talk about this, one of the greatest benefits is you cannot discriminate against somebody because they have an existing condition. That has been eliminated. And when you explain that to people that haven't been involved in this, they automatically come back and say, well, but they're going to charge me a higher premium though. And you say, no, they can't. And they're like, really? And you say, but they're going to charge me a higher out-of-pocket cost, of course. No. You have millions of Americans that have stayed at their job because they can't afford to take an insurance product that doesn't cover their condition if they want to start a new business, for example. This is hugely important, and people are completely unaware. And while about half the population does not look at this bill favorably, when they start to realize the benefits they get, you're going to see that shift. We're also going to develop tools. One of the challenges, as I've alluded to before, is figuring out what benefits are covered that are important to me. So looking at how you work that into your own life flow. Do you see a specialist? If so, how many times? Do you see a nurse practitioner or other provider? How often? What medicines are you taking? Which ones are going to be covered or not covered? We're going to provide the tools that will help you capture your own information and then be able to apply it to the plans that are offered and compare those plans so that you can get the best plan for you. Reaching those or pushing those tools out through our member networks is going to be huge, and they'll be customizable so that you can put your own logo on it and push it out so that people get the information that they need to choose the plan wisely. Lastly, I just sort of want to point out as I sort of draw this to a close, I feel like I've thrown a whole lot of stuff at you guys here. We are still in the early days of this. Health reform was created several years ago, and when it was created, it was a concept that went through this huge formulation phase. And by some estimates, we've been in that formulation phase now for more than 60 years. We finally got it through the Congress, through the legislative process, and that was a Herculean effort that really went through in a very awkward way. We're now into implementation, and we're going to be implementing for the next 9 months to kind of finalize that. And then what happens in any sort of policy-making phase, you go into the modification. You start to evaluate what's working well and what is not working. And from that, you gather data, and then you bring it back up to the policy formulation phase, and you make modifications to make it better. The reality is this is going to be incredibly bumpy. It's going to be very difficult. It's going to be better than where we were 4 years ago, but it's going to create some challenges. If you have constituents, and I know you do, that have expensive medicines, they may wind up on a specialty tier that has a very high out-of-pocket cost, or they may wind up on a co-insurance tier, which means that you have to pay a percentage of the product. In some cases, that percentage could be 50%. And in some cases, those products cost over $150,000 a year. That means your very first prescription that you fill is going to hit that $6,000 out-of-pocket cost. How many people can afford $6,000 for that first prescription? Not many. We tried to eliminate that through the legislative process and the regulatory process. We were unsuccessful. We've created some other models where you could provide what's called reinsurance, where you could have that $6,000 split over 12 months. So it would only be $500. Still a lot of money for a lot of people, but it might make it more affordable. What we don't want to have is that people get that bill and they say, okay, I'm not going to fill it, they don't take their medicine. So there's still going to be challenges here, but it is going to be a lot better than what we had. And we're going to be dealing with these modifications probably for the next 7 years. So I think a lot of people have said, let's just get to January and it'll be done. No, we're only halfway through the process in January, unfortunately. And I put this quote, and I don't know if you can see it. I think it's incredibly important that people understand this, that when things are uncertain, and for a patient, when you're going through a serious diagnosis, serious treatment, it's never more uncertain than that. When you're trying to navigate this complex new insurance program that you don't even know exists, incredible amounts of uncertainty, people don't look to the evidence. They look to the peer leaders, the norms. other folks for indications on what to do. You've got tens of millions of Americans that are going to look to you as this foundation for what they should do. And that's an incredibly powerful opportunity to help them navigate this and get to the best product for them, and to help capture the data that we're all going to need to bring that to bear on the modification side of this. And I think this is my last slide. And I have a big bottle on my desk. So.